So next, we'd like to discuss the implementation research logic model in more detail. And this is where we're going to need your help to be able to stop the video, make sure you're spending time with this logic model for your own research. It's only going to work if you're doing it in your own context. So the principles, this model developed by Dr. J.D. Smith at the University of Utah and others, is to strive for comprehensiveness, meaning thinking about the whole spectrum of the implementation research project. 2 is to indicate the key conceptual relationships related to the strategies that are identified, the mechanisms of action, and the hypothesized outcomes. We'll get into that in just 1 minute. And then we need to specify critical study design elements to organize the logic model, which is a flexible tool. So this is the standard implementation research logic model, starting with the determinants on the left-hand panel. And you can notice that the key determinants line up with the consolidated framework for implementation research. So these would be things like intervention characteristics or innovation characteristics, the inner and outer setting, the characteristics of the individuals, and then the process of implementation. So I want you to stop right here and think about, for your project, what will be the determinants that influence the intervention characteristics or innovation, and so on and so forth. Now that you've identified the determinants, you want to think about what are the strategies that can overcome some of the barriers that you might have outlined during these determinants, or what are some of the facilitators that you're able to leverage, or what are some of the contextual factors that you need to account for when implementing these strategies. Next, I want you to be thinking about how those strategies line up with the mechanisms. What are the things that you want to happen as a result of those strategies? What do you think is actually going on there? So I'm going to pause here for another minute and have you write down some of your strategies and be thinking about what those mechanisms might be. We'll give some examples in a minute. And then lastly, I want you to be thinking about how to define your outcomes. You can see the implementation outcomes on the top. So these are some of the process measures you might think about. Re-aim, we'll get into that in a minute. The service outcomes, what's happening within the clinical service delivery space, and what's happening on the clinical or the patient level. So in this case, thinking about hypertension, control rates, or reduced rates of cardiovascular disease events. Now, there can be other ways of using the implementation research logic model for comparative implementation. So for example, we can think of one strategy versus another strategy. So that would be more aligned with a type 3 hybrid study where we're comparing strategies and focusing a lot on the implementation outcomes. I'm going to pause here and help you think about how you could design a study that would compare different types of implementation strategies. So now we've gone through the overarching architecture of the implementation research logic model, and I want to walk you through some of the work that we've done that has used this in the hypertension treatment in Nigeria program, which is one of the largest hypertension control programs in Africa. Our formative work was based upon these 2 papers shown here, led by Dr. Anthony Oji and Dr. Rosemary Oakley on the bottom. The first was a quantitative assessment using the adapted WHO Service Availability and Readiness Assessment tool. We needed to go to the sites to understand what services were already there and were they ready to receive this implementation package. And so we identified that 92% of the sites had a blood pressure monitor that was functioning when we visited. On the other hand, only 41% of sites had a 30-day supply of blood pressure lowering medicines, meaning patients had to go outside to go get their blood pressure lowering medicines. There was limited training that the staff had, as well as limited clinical practice guidelines that had been implemented. We wanted to make sure that there was enough staff on site to be able to implement this bundle, and there were 5 staff, which 3 of whom were community health extension workers. We used 2 staff as a floor to make sure that there was going to be enough staff for us to implement our proposed strategies. Next, we conducted a qualitative assessment using the consolidated framework for implementation research to conduct interviews mapped to the Primary Healthcare Performance Index to identify key needs and recommendations. This was among 29 stakeholders. We identified that team-based care with training was something that was widely accepted, not only among the community health extension workers who were facing high blood pressure patients coming in on a regular basis, but also at a national policymaker level where community health extension workers were empowered to prescribe blood pressure lowering medications for patients with hypertension as long as it adhered to a national treatment protocol. That's unique. That's a very unique contextual factor in Nigeria that was a facilitator for this program. Next, we needed to ensure that there's a reliable supply of quality medicines and functioning blood pressure monitors. So that's what led to us making sure that all the sites had the medicines and monitors as part of our strategies. The sites tended to have paper-based information systems, and the reporting of patients with high blood pressure was not consistent for all patients coming in. And so it was related to training to make sure all patients had their blood pressures measured, and all patients with high blood pressure had that information recorded so that they could be brought back for ongoing treatment and care. And lastly, we made sure to use the existing village communication fora. I mentioned some of that community awareness campaigning and mobilization that we had done. And that's been critical to make sure that we were able to recruit people even during the peak of the pandemic in the Federal Capital Territory of Nigeria. Using these formative research, the quantitative and qualitative information that we collected, we've plugged in the key facilitators in black and the key barriers in red. So for example, there are effective blood pressure lowering medications, including fixed dose combinations, that can allow for easier, faster, well-tolerated blood pressure control. But the challenge of a pill-a-day approach or daily dosing of blood pressure lowering has inherent limitations to longer-term strategies, such as depot injectables, which aren't available currently for blood pressure lowering, but are available in other conditions. When we think about the inner setting, there was sufficient staff to be able to implement the proposed strategies. And the communication fora allowed us to be able to reach communities where they live to be able to drive demand. But we did note that there was low medication availability, which was an important barrier that we needed to try and figure out how to overcome. On the outer setting, this broader context, the National Multi-Sectoral Action Plan for the Prevention and Control of Non-Communicable Diseases and the Nigerian Hypertension Control Initiative showed that hypertension was a national priority for the Ministry of Health and other key ministries in Nigeria. So it was important for us to be able to align with these priorities so that the work that we're doing supports existing work being done by the government and other key stakeholders. There's also been an evolving insurance landscape in Nigeria, which was on pause because of the pandemic, but a basic healthcare provision fund allows for payment of some things like hypertensive services, including some states having blood pressure lowering medicines that would be included in a future package. So our interest was to be able to be ready for if this were to come to pass, to show how that could be effectively implemented in primary care facilities. But there are important barriers too. There's widespread poverty throughout the Federal Capital Territory of Nigeria and limited discretionary funding to pay for health services and medications. We've obviously all been facing the COVID-19 pandemic, which certainly influenced the likelihood that people would come to primary care to seek care. For the characteristics of the individuals or the actors, the community health extension workers were empowered. They were given the legal right to prescribe blood pressure lowering medicines in this context. We did note that there are sex differences in care-seeking behavior, which was a facilitator for females who are often receive maternal and child health care in primary care facilities, but was also a barrier for males who are less likely to seek care in primary care. We also noted that there's conflicting views about the role of medications to improve cardiovascular health for blood pressure lowering among many people who we interviewed. Lastly, when we think about the protocol for implementation, this was important to be able to minimize unexplained variation in care. And we also conducted data quality monitoring, feeding that information back to the sites in that supportive supervision that was occurring every quarter across all those 60 sites. It was very intensive engagement with these sites. One of the challenges we've been finding is trying to think about the right scalable unit. This is working across 60 sites with a lot of investigators, pouring in their time and effort. How can we scale this nationally? What's it going to look like? We're still working on that. I want you to think about how these facilitators and barriers might relate to some of the determinants that you've outlined in your own research. Next, I want to talk about the implementation strategies that we have previously outlined, aligned with the WHO HEARTS technical package. So we've mentioned the protocol with an emphasis on fixed dose combination therapy, registration and empanelment with audit and feedback, a system-level intervention, the provision of blood pressure monitors, and a drug revolving fund to reduce out-of-pocket medication costs. We conducted team-based care with training and supervision to improve the skills and experience of healthcare workers. And for those patients who were persistently uncontrolled, we offered home blood pressure monitoring and health coaching. Lastly, for a community mobilization strategy to create demand, we talked about the community awareness campaigns that we conducted. So next is the key step in the implementation research logic model, is thinking about what do we really want these strategies to be doing? When thinking about your implementation strategies, it's often useful to use nomenclature from other studies. So other scientists who are reading your work are going to understand, what do you mean when you talk about a protocol or registration and so on. So we've aligned our work with the ERIC investigators. This prominent paper by Waltz and colleagues has identified 73 implementation strategies and sort of 9 macro strategies shown in the polyhedron shown on the right. Now, when we think about a protocol, this tackles several of these macro strategies. So we need to adapt and tailor the protocol to the context, what drugs are available and who has input in that. Dr. Oji was a key member of the committee that developed the Nigeria Hypertension Control Protocol. Next, we want to develop stakeholder interrelationships through the development of that protocol. So it's not just a small group of investigators developing that protocol, but it's more broad than that. And then lastly, using this protocol to support clinicians. So oftentimes it's helpful to crosswalk your strategies to an existing nomenclature. I want you to take a minute now and think about how your strategies will crosswalk to this ERIC paper. Next, for the implementation strategy of registration and empanelment, you can see that this relates to using evaluative and iterative strategies, as well as training and educating stakeholders. For the provision of blood pressure monitors and the drug revolving fund, this relates to changing the infrastructure and utilizing financial strategies to reduce those out-of-pocket costs. For team-based care, this again relates to adapting and tailoring to the context. This was a real strength that community health extension workers can prescribe blood pressure lowering medicines, as well as supporting those clinicians with ongoing training and supervision. The home blood pressure monitoring and health coaching provides training and education of patients as key stakeholders in this process. And lastly, the community mobilization relates to engaging consumers. So this clear crosswalking of the strategies to an existing nomenclature will be useful for when you say what your strategy is. Well, other people understand, what are you talking about? It's also very important to think about how these strategies specifically work. So we talked about naming the strategy, preferably using language that is consistent with the existing literature, and then defining that strategy is the next step. And any discrete components operationally. When you break down your strategies, what's actually entailed in it? And when you specify the components of it, such as the actor, the action target, the temporality, the dose, that will help you understand better what your implementation outcomes should be, because it will logically flow from understanding what you want that strategy to actually be doing. Lastly, you'll be justifying this looking through the literature, ideally from previous systematic reviews, to understand what's the direction and expected magnitude of effect based upon previous published literature. So we're back to our implementation research logic model. And last, we want to talk about the outcomes. So I mentioned in the aims that we were using the RE-AIM framework on the back end: reach, effectiveness, adoption, implementation, and maintenance. I'll get into some of the details a little bit later. We're also looking at the pre- and post-training test scores. We're looking at details of the drug revolving fund implementation. For health coaching, we actually have a checklist that we want community health extension workers to be completing to understand what's happening during those home visits. We also have outcomes related to community awareness campaigns. How much did people learn during those campaigns, and did they understand what services were and were not available in primary care? Ultimately, we're looking to integrate hypertensive services into primary care in Nigeria. And to measure the clinical or patient-level outcomes, we've used an interrupted time series study design where our primary outcome looks at the change in slopes for treatment and control during the pre-intervention period with the post-intervention period. We often will use our implementation outcomes to explore and explain the variability across key subgroups, and that could be such as age, sex, or level of rurality. Think about some of the key subgroups in your community that you think are important to be measuring and monitoring during the course of your study.